I was introduced to Jessica with CEO of Tria Health through Daniel Janes. Raise your hand. He's with Gallagher. He's on our board. Trusted voice of the employer of employers. And then Rhonda Wright, who is with Academy, and we heard a lot about GLP-1s. So today we've got a session on GLP-1s, and then tomorrow we have 2 other sessions with GLP-1s, all from different angles. I know that's a big thing with Josh. I mean, there's a way to deal with this without breaking the bank.
Good afternoon, everyone. My name is Rhonda Wright. I am Senior Benefits Manager at Academy Sports and Outdoors. If you are from Texas or any of the southeastern states in the United States, you're very familiar with our brand. We have over 300 stores in 21 states, 3 distribution centers, and 1 corporate office here, in Katy, Texas. We've been in partnership with Tria for about 5 years, and we decided that the disease management that we had in place with our previous PBM to help us control costs for different diseases, they weren't really being utilized as much as we would like them to for the purposes of cost containment. So we decided to partner with Tria to widen that gap a little bit, or close that gap, so to speak.
My name is Jessica Lee, and I'm the CEO and founder of Tria Health. I'm also super passionate about pharmacy. I'm a pharmacist. And Tria was started with the intention of putting pharmacists back in the role of what many pharmacists go to school to do. At the end of the day, when I said I want to go be a pharmacist, I definitely didn't think I was going to sign up for a McDonald's drive-through situation where I was dispensing drugs and just giving everybody a few minutes to say, do you have a question? Okay, good, see you later. I went to school for 6 years to really help understand how medications worked, how they interacted with individuals in their individual DNA and their individual disease process, and also really ensure that, number one, education was a big part of what we do. Healthcare is a very complicated situation for most people, and especially when you get diagnosed with a chronic disease, that's very overwhelming. And then to understand what to do with that on the top of the complexity of benefits, it's very, very challenging. So Tria was founded in 2009 as a chronic condition or a chronic care management program with a pharmacist focus. 80% of chronic conditions in the United States, and we don't have to argue that that's the right thing, but 80% of chronic conditions in the United States are treated with medications. And so that complexity, along with polypharmacy, and I think people are surprised about the number of individuals who have chronic conditions and the number of medications that they're on. Our average patient, and we only work with self-insured employers, so we're talking about employed people generally speaking here. The average patient has 10 medications, 4 physicians, and maybe 4 to 5 chronic conditions. And that seems overwhelming. Usually when we talk,
Yes.
You're like, that's not possible.
It is very much so possible, and what we've seen since partnering with Tria is that our average team member will go from anywhere from taking 8 to 10 prescriptions down to, I'd say, 4 to 5, and that's with the work that Tria is doing with our team members. We're seeing, compliance move. We have a 54% compliance rate with the folks in our footprint that have diabetes, 43% for folks who have heart disease. So we're really seeing that improvement in the advice that they're getting from our partners at Tria.
Yeah, this case study is really about using it to illustrate what we do with GLP-1s. And it's only because I'm guessing that everybody in the room knows what GLP-1s are. You've talked about it, you know about it. So it's easy to illustrate the role that pharmacists and Tria Health play in the treatment of disease. GLP-1s have been around for a long time. We all know that. We just have heard about it recently because it's obviously very important in the media related to the treatment of obesity. But diabetes is a condition that we've been treating, GLP-1s have been treating diabetes for years. And the reality is that the complexity of using medications for disease states is sort of a multi-challenge situation. Many times you have multiple physicians prescribing. I mean, we all want to think that the world is such that everybody has one primary care provider. And the reality is, even more today than ever, people are seeking care on their own from multiple providers, additionally adding in telehealth and things like that. And we understand the reason for that, the convenience for that, and the purpose of that, because we're running out of primary care physicians to provide these care. But at the end of the day, what happens is you may be put on a medication, such as a GLP-1, and then you have a side effect. We know that if you, in 2025, this year, there was a JAMA study that said the discontinuation rates for GLP-1s, and not just in obesity, we're talking about diabetes, which is critical to treating long-term complications. The adherence rates were low 30s, 40s, and not uncommon. And the amount of time people were on these drugs was shortened as well. And so I'm not talking about obesity here. We can argue that that maybe is something that maybe people don't use as long-term, depending on how and why they're using it. But the reality is, if you're diabetic, even type 2 diabetics, generally speaking, you don't get to be on a med for like 2 months and then you're done. The reality is that persistence to that. And it sometimes comes down to the right drug for the right patient at the right time. I also remind people all the time that as a pharmacist, the most expensive drug as an employer that you're paying for is the one that's not doing anything. You might as well just pour it down the drain. It doesn't matter if it's 5 cents or $5,000. That drug isn't working for that person because that person may not be right for that drug. And I heard somebody say it earlier, sometimes the expensive drug might be the right one for that person. And the reality is that opportunity needs to be evaluated to ensure that you're in the right therapeutic class. But the other thing about these GLP-1s is that the discontinuation rates are likely due to the complexity and side effects. And the reality is that if you can work with a pharmacist to understand why and how these medications, so education, why are you using this medication? What's the length of time you might need to be on it? What are the side effects that potentially happen and how this side effect can come down the pipeline? Your opportunity to benefit from that drug is obviously higher if you understand all of those things. And so the complexity around GLP-1s has allowed us to illustrate the example of why when you get prescribed something by a physician, the importance of having a pharmacist alongside you in the journey is really, really critical to ensuring that you're getting the outcomes you expect. Something that's important also to note beyond just adherence for these is the reality related to what we call drug-related problems. As pharmacists, we spend a lot of time in our education talking about DTPs or drug therapy problems, which doesn't probably mean much to anybody, but at the end of the day, people have issues with medications that need to be solved. Sometimes it's adherence, sometimes it's dose too low. Once again, if you're on a drug and it's not getting you to where you need to be, that's not the right situation, right? Dose too high, side effects or toxicity concerns. So one of the things that we are finding most consistently over the last 10 years with GLP-1 usage in diabetes specifically, but also related to obesity, is that on average, a person who's on a GLP-1 is going to have 1.3 or 1 to 2 drug-related problems related to that medication alone. And a lot of times what we were finding, particularly in diabetes, which should be alarming to each and every one of you employers who is paying for those GLP-1s, that we're finding that the dose is not optimized to get the outcome. Problem is they get started on a dose, and either the physician's not comfortable with the dosing titration, or the person has a side effect. That medication is going to cost the same at the low dose and the second dose and the high dose. That's common in diabetes medications. But you're not getting the hemoglobin A1C expectation that you're doing. So the reality is that you're basically paying for suboptimal outcomes. And that's why it's really, really critically important to evaluate what's going alongside the use of these expensive medications. And like I said, I'm illustrating it for GLP-1s because everybody knows it, but this happens with other disease states as well. We see it in hypertension all the time. 50% of people who are diagnosed with hypertension, who are on medications, are not achieving the goal of reduction of blood pressure, which allows for prevention of cardiovascular events down the road. So this is all really, really important and illustrates another reason why pharmacists could be alongside physicians to ensure the best health outcomes.
So we see here one of our counter. He had 3 physicians with 7 conditions. And through the work with TRIA Healthcare, the patient is now managing their diabetes. The TRIA pharmacist recommended to discontinue a medication, I'm not going to try to pronounce that, and increase the dose of their Mounjaro in order to optimize the opportunity for weight loss and to improve other outcomes. So this is what we basically see with all of our team members that engage with TRIA Health. We see that there's better education, there's better adherence. They understand now that, you know, they're doctors, they must advocate for themselves and speak with all of their doctors and make sure those doctors are communicating when they're prescribing medications, because oftentimes we see people that are on 10 different medications and 3 of those medications may be doing the same thing. And that's where TRIA comes in. You know, they help our team members figure out which medications are better for them, which in turn leads them to saving money on copays, which also passes that savings on through to Academy.
Little known fact for everybody in the room, you just have to say whatever the name is with confidence. Not anybody's going to challenge you on what the pronunciation is. So just say it with confidence. No one's going to question it. But this is a great example of illustration of, you know, by no fault of anyone's, sort of the journey of healthcare for people. They were on 2 medications for diabetes, which isn't uncommon. I mean, it's not like ruled out or not appropriate, but the reality is that there were situations where one of the drugs was actually causing weight gain, and then they got put on GLP-1, but then they were also at risk for low blood sugar. So what we were seeing here was sort of an unfortunate, not optimized medication regimen, which really had the opportunity to improve the outcomes. And also, something that's really, really critically important is everyone always thinks pharmacists like everyone to take lots of drugs, and the reality is that we want you to be off drugs. Like, that's the healthy patient who isn't taking medications is ideal, right? Like, that's true healthcare, right? That's the journey of hopefully what everybody's on. So just a quick sort of oversight of how a pharmacist can play a role in the care of a person who has chronic conditions is really ensuring that not only are the medications right, but also understanding the signals alongside the symptoms or feelings that individuals are having. And I kind of alluded to the fact of the importance of optimizing medications to get the outcomes. And the reality is that using resources for enhanced services. So one of the things we do, our pharmacists, when they engage with a member on, for example, Rhonda's team, you know, the employee will work and they'll have their own personalized pharmacist to work alongside them, sort of their primary care pharmacist to work alongside them. And then we may utilize enhanced services like blood pressure monitoring, cellular blood pressure monitoring, cellular blood glucose monitoring, and cellular weight scales with composition to understand exactly how they're responding to these medications and do it in a more timely manner. The other challenge a lot of times that we have is individuals have a difficult time getting into their physicians, and so they get on a drug and they stay on a drug, and the next thing you know, it's a year later and they're still on the same drug, but we're not getting what we need out of that drug. And so the reality is using enhanced remote patient monitoring cellular devices that allow the member to be able to share information with the pharmacist, and that pharmacist then can also act as a liaison to the primary care physician to ensure that we're getting the best outcome. And sometimes the outcome is, let's get rid of a medication because it's increasing complexity, it's increasing cost. So something that TRIA Health does very much differently than maybe some of the other when you hear pharmacist and pharmacy, is that we're really focused on discontinuation and making it simplified for the member. Because at the end of the day, the individual, the more simplified their regimen is, the better off they are to adhere to that and ensure that you're getting the best outcomes from that.
Absolutely.
And I think the other thing that's really, really critically important here is to understand that from a GLP-1 perspective, it's not going away, right? We've only just hit the cusp of the pipeline for medications that really treat metabolic disease. And at the end of the day, you know, as employers, We worked with many employers who were shocked by the fact that they were paying for GLP-1s and didn't know they were paying for GLP-1s. And the reality is that what we were able to do was partner with those employers to ensure that if they carved out this, like said, we don't want to cover weight loss on our plan, you can potentially put in a pipeline that controls the evaluation of these medications for your member, ensuring also that they get the education alongside the use of those medications to drive the best outcomes. So using health coaches and dietitians and pharmacists who know the medications and understand the expectations of the medications is really how you can drive the best outcomes. And many of those employers that we worked with that had unbeknownst to them coverage of GLP-1s, when they took it out and they said, we want you to be working alongside a team of individuals who can help you get the best outcomes, we're able to see a 37% reduction in their utilization by just saying, we need to find the right patient with the right time. And I'm not talking about just PA criteria, I'm talking about partnering with someone to understand the clinical value of their outcomes and what they can get. So that's that. So we have an opportunity for questions.
I have a question.
Yeah.
Is it prospective outreach? In other words, does the pharmacist, regardless of any other thing, reach out to the patient on a regular basis, or do they reach out when they see they're not monitoring, when they're not doing this, that, or the other, or is it a little bit of both?
It's
Both.
a little bit of both. Yeah, go ahead. I'll
it's a
let
little
you
bit
speak to your experience.
Absolutely, it's a little bit of both. So when TRIA gets that information from our PBM, they go through that data, they analyze it, they pinpoint those folks that they do need to do the outreach to, those folks that may be on multiple medications, those folks that they may see they got the drug for 2 months, then they didn't get the drug for 2 months, and then they got the drug for 2 months. So they look for all those different types of things to pinpoint who they will do the outreach to, and they do a very, very good job of doing so on a regular basis.
And then you leverage data to help understand when we need to reach out, right? Like if you're seeing a spike in blood pressure for someone, we need to know, like, gosh, what's going on? Do we need to talk to you and your physician about potentially a new medication? So those are the ways in which we create that continuity of care.
The outreach is through, i.e. Zoom modality, text messaging,
Telephonic.
yeah, all of the above. I got time for another question if someone has one. Dr. Haywood.
Thanks for the presentation. Quick question on the member experience, so I can make certain I understand how their decision making is it part of the process. And then I'm a zealot about number needed to treat and number needed to harm. And I didn't know as part of your process, this is a little in the weeds, so I apologize. So this is more for you, Jess. Do you share that information with a member? Because oftentimes when as a physician, when I share it to the members, how many individuals that are similarly situated to them are going to benefit or not, they might change their decision making about whether or not they want to be on the medication and be on the medication for 5 years to be able to get a benefit. So just member experience and then what information you share with the member.
Yeah, so first and foremost, I want to just reemphasize that TRIA Health pharmacist, we don't obviously do any prescribing. We're not under any type of prescription authority in this situation. We really are looking at sort of starting at scratch. What are you taking pharmacologically? What's on your claims file? What are you taking, that you may have seen as a supplement that's going to fix everything for you and other over-the-counter things? So we're focused on trying to understand sort of their experience alongside their pharmacy claims and their medical claims. Once we do that, then it's really evaluating if we see any opportunities to improve outcomes. And a lot of times with that, we have the opportunity to do disease education and understand, here are your options. You may not need to be on this drug if you can add this non-pharmacological experience into your world. So there is, I wouldn't say we get not per se, and I know what you mean, we're not getting into the number needed to treat such situations, but our pharmacists, we're all PharmDs, we all focus on evidence and clinical outcomes and finding the right mix for the patient. So that's critically important to the part of what we do. And I would say that a large part of what we're doing is advocating and educating so that the member gets the best situation for them. And you obviously, as a physician, know that this is part of sort of standard practice in healthcare and health systems where you have a pharmacist on the team to be the expert. And we're just trying to give that opportunity to individuals who are out in the community that don't have that opportunity, or don't have the pharmacist from the 50s that was behind the counter that knew everything about you and your family and could really help tailor things to you. So that's really why we do what we do. And I will say too, my husband and your wife can't talk because I also am addicted to education and would love to get another degree, but my husband suggested it's not time for that. So we can't have them together in a room.